Uh, Good afternoon, good morning, good evening, depending on where you are on our global map. A warm welcome to the fourth episode of our series of webinars on men and HIV, which we call the Global Men and HIV Technical Working Group, which focuses on the men and HIV agenda. So as usual, as you've always done before, we are going to be sharing the slide decks and the recordings after the webinar. And also I would like to hear your thoughts and your interests as we wrap up the webinar through a poll. So would like to kindly ask you to participate in that poll. It's just one question. There is French and Spanish interpretations available. So on your Zoom, if you click that globe looking like icon, and then you select your language of choice. We have got a very exciting and interesting agenda today with great presenters and great work which they're going to present to us today. But to give you some bit of background, because we know every time we run this series of webinars, we always get new people joining for the first time. MENT, which is the Global Men and HIV Technical Group, was launched last year in March. And this was as a result of seeing the need to discussing the Men and HIV agenda, to push the Men and HIV agenda, and also to be looking at what the data is saying, what are the messaging, and how we can support countries and partners that are working on this topic. And as part of that global working group, we ran a series of these webinars. And as you might have seen in the title of this webinar, it says episode number 4, which means we have done 3 episodes of these kind of webinars before. And the whole idea behind this series of webinars is to try and coordinate activities that are related to improving outcomes for men across the HIV cascade, as well as support advocacy efforts with global partners and key stakeholders. Also to support development of operational guidance for improving HIV services for men, including identifying interventions and review of technical documents. Also identifying, collecting, and share best practices, case examples, and tools for reaching men. And this is the aspect of this global working group that is covered through this webinar series. Also creating a platform to disseminate guidance, briefs, and lessons learned, and also support scale up of effective interventions, including providing technical assistance on men and HIV. So that is all about the MENT group. And in this part of the webinar series, we're going to be looking at presentations from both partners that are supporting countries in implementing this, and also from government people in the countries as well that are working or covering the Men and HIV agenda. If we zoom in on that, which I didn't expect you to see the small text, but if we zoom in on that agenda for today, this is how it's going to run. We're going to have a presentation by Michaela Rodrigues from PSI Mozambique, who is going to cover reaching men by addressing fear of social and sexual death, early results and lessons learned from the Somo Iguis campaign in Mozambique. I'm not sure if I got that pronunciation right. And then we will hear from Josephine Najuma, who is going to present on barriers and facilitators of male engagement in community client-led antiretroviral therapy delivery groups for HIV care and treatment in southwestern Uganda. And then we'll hear from Chapaigo, and we have 2 presenters here, A and Manya, A from Nigeria and Manya from the USA. We're going to share insights from their campaign called Vala, how they built a social media-driven campaign that cares about men in Nigeria. Then we'll hear, maybe some of you could be familiar already with this work from the Eastern and Southern Africa region, who recently launched a male engagement framework. So we'll hear from Marietta, who will give us highlights of this framework called Male Engagement in HIV Testing, Treatment, and Prevention in Eastern and Southern Africa. It was a great launch that was done recently, very wide collaboration across different partners and UN agencies there. And then we have a question and answer discussion that is going to be facilitated by one of the co-chairs of this MENT group, Sean Malone from PSI, and then closing remarks from Wale WHO. So this is how our agenda is looking like today. Very exciting presentations with insightful data to be covered. So that's all I have. Before wasting more time, I'll give to Michaela for the first presentation. Over to you, Michaela.
Thank you, Lysias. So, hi everyone. Sorry, there's the sharing missing.
The share. Are you able to share, or should I?
Okay, just sharing, sorry. Okay, please confirm if you can see, I believe so. So thank you, Lysias. So my name is Micaela Rodrigues. I am the marketing director of PSI Mozambique, and I am managing the EPIC project here in Mozambique. It's a pleasure to be here today to talk to you about how we have reached men by addressing the fear of social death and sexual death, by sharing the results of our SBC campaign Somos Iguais that we have been running in country. So I will start with talking a bit about the context of men living with HIV in Mozambique, some of the key findings that we have learned, and it will likely resonate with some of the findings you have of the insights you have in your countries. So in Mozambique, adolescent boys and young men from the ages of 15 to 29 living with HIV have some key characteristics that make them a priority group to control the ongoing epidemic in country. So they have especially low coverage of ART. They are much more likely, according to PEPFAR data, to drop out of treatment and to remain out of treatment for longer periods, longer than 6 months. They are usually mostly asymptomatic. They are less likely to interact with the health system for different reasons, and they are sexually active. All of these key combined characteristics make them one of the major forces for the new infections that we see in country every year. So the project has started with an insights validation from the work previously done by the team in South Africa, where we wanted to understand with men what were their key perceptions and attitudes when linking to treatment, what were their feelings, their external influencers, so that we could know how to address these key challenges. When we have talked to men and asked them how could we improve their adherence to treatment, we have learned that men living with HIV fear social death more than physical death itself. So they told us that they fear being excluded by their closest friends. They fear losing the respect of their communities and families. They fear the shame of being associated with a bad behavior. And they also fear the stigma and discrimination from different stakeholders, namely their employers. So men told us that if you want me to take ART, you need to change the way my family and community sees people living with HIV. The key solution, the proposed solution for this particular challenge was to develop a SPC campaign focused on men living with HIV, which is called Somos Iguais. This campaign aims to normalize HIV in the Mozambican society, because when we say to everyone that people living with HIV are normal, they are healthy, safe and productive members of communities, when we normalize treatment, we are able to reduce stigma and create an enabling environment, a favorable environment for people living with HIV to start and stay on treatment. So we have proposed a single and national campaign with one message tailored to people living with HIV and to their communities. With the campaign, we want to be able to sensitize, to provoke, and inspire change within the communities, within the influencers of men living with HIV. The campaign was divided in two phases. So the second one is running now. And the first phase of the Somos Iguais campaign aimed to start creating an enabling environment for the treatment adherence through the reduction of existing perceptions of stigma and normalizing HIV, as mentioned. And with this, we would be able to retain and recover men who have abandoned ART. So the campaign name means we are the same. Together we win, so that we can be able to compare people living with HIV to anybody else. The design materials and messages pretend to break the existing ideas and perceptions around PLHIV by showing them in their daily tasks, in their daily routines and challenges, just like anyone else. This was done through a main TV spot and complemented with different testimonials videos of people living with HIV who came to us to share their positive experience with treatment, the difference that treatment made in their lives, how they are able to have children that are HIV negative, how they are able to keep their social life, to keep their work, so how they were able to keep their life as usual, as normal. And here, one of the key learnings that we had, and also linking to other projects, is that the messenger is the message. So bringing this message from people living with HIV to the communities, to the general population, was very important to create the needed resonance and empathy with our audience. So showing that anyone can be the person that is talking about this experience. It's not some famous person that it's unreachable. It's someone that it's like me, and that has gone through the same challenges as me. From the first phase of the campaign, some early results that we have. So we had more than 2,000 spots being aired on national television, with an estimated viewership of more than 15 million. Almost 2,000 radio spots aired, and 8 million estimated listenership. We were also creating visibility and message recall with billboards through the different provinces of the country. And we were also present with key influencers, television, talk shows, and some merchandising activities. So we brought some of these people living with HIV to talk about their experience on mass media channels. And we also had our social media component, which was very important, mainly to engage on one-to-one conversations with men living with HIV. We have made an online survey to understand the reported learning behaviors around the campaign. And we have learned that about 85% of the participants report to have learned something from the new messages. And the most frequently shared mentioned learnings are around the importance of medication, and around the fact that you can lead a normal life living with HIV. On the reported behaviors, we have seen that almost all respondents mentioned to have discussed or planned to discuss the campaign with someone. And more importantly, 17% of them sought a health service as a result of the campaign. And 58% mentioned to plan to do that in the near future. On norms and perception, we have seen that 48% of the respondents report that the campaign has impacted how they see people living with HIV, and 69% report that they would have sexual relationships with someone who lives with HIV. When we look at indicators, and we see particularly the number of adults of male adults that has been newly enrolled on ART, we can observe a high increase in this indicator, but we need to take into account that we cannot attribute this alone to the campaign itself. So several activities were happening in country. We were not able to exclude those other variants from these numbers. But we can see that from the quarter that the campaign was launched, so Q3 of 2021, we see a large increase on a high increase on these indicators. So we see that the average of the quarters following the campaign start is 50% higher than the previous 3 quarters, or 65% higher if we compare to the 5 previous quarters. Sharing some testimonials, some words from our target audience. I have highlighted the key message to show a bit what people are saying. And we see people saying that they realize that there are more people in their situation and that they should take the reins of their lives and be responsible, take medication. That it was not easy to accept that I was HIV positive, but accepted it and adhered to the treatment. That at some point it improved my self-esteem, for the stigma had consumed me. And with the campaign, I had the courage to start a treatment 8 months after discovering that I am HIV positive. After seeing the TV spots, I searched your Facebook page and was able to talk about it. So this was some of the feedback we got from the first phase of the campaign. As I mentioned, right now we are in the second phase. So while the phase 1 was addressing the external influencers around the men living with HIV, was focused on changing perceptions and misconceptions. On this second phase, we are focusing on men's behaviors and emotions, and trying to create a very clear call to action that touches their lives and their behaviors. The second phase was designed with 3 archetypes in mind, which are the 3 most common that we found in our target audience. So the campaign keeps the same slogan, so somos iguais, and now we have Numa Elo, which means we are the same, we are fine. I am doing the HIV treatment, and you. So we created a clear call to action that tends to motivate men to rethink about their behaviors. What men told us about this message is that they feel that it motivates them to go into treatment and encourage other men to do so. The campaign touches, again, the mass media channels, television, radio, billboards. We will work again with a central spot and people and men living with HIV to tell their stories and their experiences with treatment, how that impacted their lives. And we'll be working as well on social media and community activities. I will show the spot that was created and with the 3 archetypes that were mentioned. I will then share the link on the chat of the different materials that the campaign includes.
Yes, I guess there's a problem with the audio and the sound, but I'm sure when we share the video and the presentations after the webinar, you'll be able to get the sound, Michaela.
Sorry, I heard someone talking over the sound. Were you able to listen to the sound?
No, Michaela.
We could not hear the sound,
So
but I think, yeah, the video was quite clear, and hopefully when we share the recordings with the slide decks, our colleagues will be able to hear the sound, if that's okay.
Sure. Okay. Sorry about that. I'll also share the YouTube link so you can see it later.
Yeah.
These are the three archetypes that are talking to men through the different spots, and shows the kind of messages and materials that we have been showing, promoting at the national level. This campaign was just launched about a month ago, and we will have more information on its impact by the end of this COP, and I look forward to share it with you all in another opportunity. Thank you.
Thank you so much. Thanks, Michaela. This is a great presentation addressing this aspect when it comes to men and HIV work, addressing the issue of fear. Kindly remember to post your questions on the Q&A function of the Zoom platform for any questions you have for the presenters as they present. They will be responding to your questions as we go along. We'll also have a dedicated question and answer session where you be able to also speak and ask questions to specific presenters as we discuss. Our next presenter will be Jovial, who is going to present the work done in Uganda, looking at barriers and facilitators of male engagement in community client-led antiretroviral therapy delivery groups for HIV care and treatment in southwestern Uganda. Very interesting data, and it is my understanding that this work was recently published. So over to you, Jovial, for the presentation.
Yes, good afternoon, everyone. Let's have one of my colleagues project the slides.
I can project for you from here. I think I have the slide decks.
Thank you. Yes, good afternoon, everyone, once again. My name is Shemera Jovial, an intern pharmacist at Ginger Regional Referral Hospital, presenting to you a research I did with my colleagues. The study is entitled Barriers and Facilitators of Male Engagement in CCLADs for HIV Care and Treatment in Southwestern Uganda. Next slide. Sorry, next slide.
Maybe they could be moving slow on your side. On the introduction slide, right?
Yes, I'm still on the second slide. My presentation will be in the form of the following outline. As you all know, art improves the quality of life of people living with HIV, that is lowering their viral load, improving the individual's immunity, thus reducing the chances of getting opportunistic infections. This can only be achieved through better art access and adherence. In Uganda, I don't know the situation may be in other settings. Male do not attend healthcare services at the hospital. And that's why male engagement in HIV programs is still a persistent challenge and has resulted in poor utilization of HIV care services. In 2016, the World Health Organization endorsed the differentiated service delivery models. These include the hospital-based, that is the facility-based, and the community-based. Under the facility-based, we have individuals coming to the health facility to pick the medication for themselves. Under the community-based, we have specifically the community client-led ad delivery groups. These are groups of 4 to 12 people, whereby one of them goes to the facility to pick the medication for the rest. These groups are formed voluntarily. To be in this group, you must be 18 years and above, have a viral load that is equal less than to 1,000 copies per mil, not on TB medication, not on any substance of abuse. And these people are formed, these groups are formed by the people from the same community with the same interests. In Uganda, there are only 6% of the people living with HIV are in sick lads, and majority of these are women. Mantel and his colleagues reported that stigma, information gap, and masculinity were the reasons as to why men are not involved in these groups. They believe that hospitals are places for women. In southwestern Uganda, sick lads were adopted 1 year ago, but there are very few men involved in these sick lads. Therefore, we set out to explore the barriers and facilitators to male engagement in community client-led ad delivery groups for HIV care and treatment. Next slide. Our study was an explorative, descriptive, qualitative study design that aimed to understand the barriers and facilitators to male enrollment in these sick lads. Our study took place at 2 health center 4s. A health center 4 is a mini hospital that is headed by a medical officer. Our study was carried out among the people living with HIV, those that were enrolled and not in the sick lads. We also interacted with some of the key informants that had experience in these sick lads. Some of them were females that were seniors at this. The others were at clinic in charges and counselors, whereby we had to formulate the 2 forms of interview guides, the key informant interview guide and the in-depth interview guide. We analyzed our data thematically. Before conducting our research, we had to obtain ethical approval from the Mbarara University of Science and Technology Research Ethics Committee. Also obtain voluntary written consent form from the participants before the study. In total, we conducted 16 interviews, and that was the 7 in-depth interviews and 9 key informant interviews. The in-depth interviews were conducted among men living with HIV, whereby 5 were in the sick lads and 2 were not into the sick lads. Their ages ranged from 35 to 51 years. Among the key informant interviews that we interacted with were 2 peer leaders, the 4 senior females that were in sick lads, 1 counselor, 1 clinic in charge, and 1 nurse. Their ages ranged from 30 to 60 years. Next slide. Another. Next slide. Then the other one, the other slide. Yes. After interacting with our participants, we came out with these themes that were better explained with these sub-themes. And the motivators for men to join these groups was reduced transport costs. In these groups, you realize that it's only 1 person who goes to the facility to pick for the rest. The rest would contribute like a quarter of what they were supposed to spend on transport, thus helping them save transport costs. By doing that, since there were also reduced numbers of people going to the hospital, they also reduced on the waiting hours at the facility. Also, this also helped them reduce on the stigma. It helped them that they are not identified by other people that had come to seek other medical services from the same community as HIV positive. Others told us they were encouraged by other men to join these groups. As one of the participants said, so it helps you in always remembering to take your medicine. Your fellow members will always remind you to swallow your medicine. Then they also added that they helped them about the poor attitude by the health workers, specifically female nurses. They were complaining about how they are treated badly once they reach at the health facility by the female nurses. Among the challenges they faced when they were joining these CCLADs was the number of people in the same area, which was still low. This is because people in that same area do not want to disclose their status. As one of them told us, we don't know ourselves in the village, and some instead go to further health facilities, so such people are not allowed to join these associations. Another challenge raised was lack of trustworthiness. You realize these groups were not specific, could be a combination of males and females. Here in Uganda, females are looked at as gossipers. They feared that women would go out and let out their secrets within that group. Another challenge was drug abuse. As I had earlier told you, anyone found to be abusing any substance was not allowed to join these groups. Men in this community take a lot of alcohol and end up forgetting to take their medication. As a result, the viral load would be high. Another thing, what was mentioned majorly by the key informants was funds to facilitate the CCLADs. These key informants were trained on how these groups operate, but they didn't have funds to organize and call the men living with HIV to come, and they train them on how these CCLADs operate. Among the perceived facilitators that they told us were incentives. They say that if they're given incentives in form of monetary and non-monetary form, it would make these groups more appealing to them. As one of the participants echoed, the biggest thing would be that if you can help us with funds so that even if we don't give the person receiving medicine money, your funds are available for transport for him to use. That would be very helpful. The others said, incorporating income generating activities within these groups would help and men join these groups. These income generating activities they proposed were poultry farming, and this would also help them, not these groups to be identified as HIV positive groups, but groups that are helping men grow economically. The other perceived facilitator was voluntary formation of these groups. These groups were left for them to form at a free will. They would choose the people they would wish to be with. Next slide. Some of the perceived barriers were information gap. We realized that most men were not aware of the existence of these groups. As one of them told us, as for me, I've never heard about these groups. Actually, they'll help us a lot. They also feared the HIV disclosure. Within groups, they feared that riots would result within those groups, and some of the members would end up disclosing their HIV statuses. Also, men are secretive. They don't want the other community members to know that they're HIV positive, because whoever is HIV positive is believed to have multiple sexual partners. And some of the proposed strategies they told us that would help us to best implement these CCLADs was closing the information gap. They told us once we are to bring seminars, we should extend them to the lowest administration level, whereby one of the participants said, when they bring seminars, they should also conduct them on the health center one, so that even men who don't have time to come here at the health center can go for checkups and receive their HIV medicine, which will make them join these groups. They also promised that they will inform their fellow men so that they can inform the other. That is the snowballing method, so that everyone gets to know about the existence of these groups and they find the eligible members to join these groups. Next slide. we came to realize that men rarely go to these health facilities. Though information about these CCLADs was frequently shared at the clinic, knowledge of how these CCLADs operate was a major barrier to enrollment of these men into the CCLADs. And this also confirms the study done by Mills and the colleagues, whereby they confirmed that men are poor health seekers. Another major key facilitator to male enrollment was the voluntary formation of these groups, whereby they're given the free will to choose who they want to be. And this brought about the flexibility in the formation of these groups. A study carried out in Malawi found that income generating activities were initiated and valued, yet they were not part of the formal structure of CCLADs. Therefore, provision of funds for income generating projects in these groups would be highly valued and will encourage more men to join these groups. Next slide. We conclude that active male participation in these CCLADs will solve the gender disparities in art access. And again, addressing the barriers to male enrollment in CCLADs may encourage enrollment and engagement, leading to improved satisfaction and enhancing treatment outcomes for men, thus improving the quality, their quality of life. Financial literacy, support for money generating activities for men would need to be put in place to increase men enrollment and retention in care. Next slide. We recommend that improving social and emotional support will optimize men enrollment into CCLADs. Also, incorporating other activities, not only mental or social activities like football, other activities into CCLADs may make these clubs more appealing to men. We are also happy and willing to partner with any stakeholders in HIV care to do a multi-site study to explore the impact of CCLADs on male engagement, retention, and adherence to art. Next slide. We acknowledge the above team for the support they provided to us when we're doing this research. Next slide. Since we are a team of young researchers, would like to acknowledge the above team for the support, for the funding they provided for our research. Next slide. This slide is already published. Whoever would like to get more about the paper to read more would access it through the link provided. Thank you for listening.
Thank you so much, Kushemererwa. Thank you for such a brilliant presentation covering an important aspect of the Managed HIV agenda. I think for those who have been able to follow through the different series of webinars, we saw kind of a different angle from the start in Malawi by Kathy Davo, highlighting that men are coming to facilities and there are missed opportunities there, that services are not provided to them. They are coming. And then here in a different context, we are seeing that the health seeking behavior is highlighted. I think in the context of Uganda, men are not seeking health services. I think important, different contexts, important aspects to be able to remember when it comes to how we're messaging around the Managed HIV agenda, and something maybe worth of discussion when we go to the discussion session. I'm glad the next presentation is looking at how to build a social media driven campaign for a very specific context, that is for men in Nigeria. I'd like to hand over to Ehi and Manya, who are going to present on this work done by Chapaigo. So over to you, Ehi and Manya. I'm not sure in what order you're going to present.
I'm going to start, but could you please stop sharing your screen so I can share mine? Okay, here we go.
Yeah.
Okay. This should be it. Are you guys looking at it?
Got it.
Okay, great. Good morning, good afternoon, folks. It's so lovely to be with you. Thank you so much for the invitation to share with colleagues and see friends, old and new. And I'm really happy to have as many of you in this group because a lot of the work that we did on Valor built directly on some of the work that all of you have been doing. And we were looking to take some of the insights that you all discovered and that we heard about in such gatherings and action those in Nigeria. So I'm just going to go through a couple of slides and then hand over to my colleague Ehi, who's going to talk about how Valor has rolled out in Nigeria. So I'm just going to touch on this. Valor has been a part of the RISE initiative, which was a global cooperative agreement supported by PEPFAR through USAID. And it has been in operation, really operating and seeing clients since the 1st of October in 2019. And Valor has been implemented in 4 states, Adamawa, Akwa Ibom, Cross River, and Niger states. I don't need to belabor this point, but the reason that we worked on Valor is because we saw a significant opportunity and that there was a big need and use gap among men for antiretroviral treatment. So our big strategy here is to, so here's how it works. A man is avoiding getting tested because he's afraid that he's positive. He knows he's taken risks and he doesn't want to be shamed for these risks. So a Facebook ad pops up on his feed telling him that new HIV treatments are no big deal and that even if he's positive, he's going to get to keep what matters. So I was definitely paying attention when we talked about social and sexual death. He believes it because the ads talk about easy 1 pill a day treatment and having a friend to help you through the process. He feels like these people are going to treat him like a VIP. So he clicks on the ad and sends a WhatsApp message. A very cool VIP guide encourages him, answers his questions, and makes him feel brave enough to set up an appointment at the nearest clinic. The guide reassures him that the team at the site is going to be waiting for him. And the guide even follows up, checking in on him on the day of his test, making sure he's all right and he's got the courage, and reminding him of other times in his life that he found the courage to do difficult things. For some men, seeing the ad a few times, and the average was 6 repetitions, was just the push they needed to finally get the test, and they didn't even go through the WhatsApp VIP guide. So the Valor Project was building on that concept, but we had a lot of work to do together with men to figure out exactly what our message was going to be and exactly how to talk about this service. And there's a lot of things that we knew from other folks' work, and we particularly leaned on some of the work that Sean and his colleagues have been doing, and the Coach and Pilo work. So, we had all these things that we already knew. And from Valor, we learned some more nuance to that, but I really wanted to highlight 3 insights that were very important for us and key drivers of our strategy. So the first one was that we thought about courage because we know that there's fear, but we looked at the flip side and said, well, what is courage actually? And how do we build courage? And the idea that we came on is that you rarely have the courage to face something from beginning to end when you first begin it. And you don't need the courage to do the entire thing from where you are. What you need is the courage to take the next step. So that really helped us to think about how do we break down the risk or the courage that you need into something that feels almost easy. So like clicking on WhatsApp is a really low barrier. It doesn't take a lot of courage to click on a WhatsApp. It takes a little bit of courage to say hi. It takes a little bit of courage to engage in a conversation. And our idea is that if you can catch those moments and encourage somebody, that then it becomes an issue. It becomes a situation where they're leveling up their courage, and you can remind them of the courage they've already shown to get to this point before they find the courage to take just the next step. We also saw that messages about living positively with HIV come way after after you have a positive diagnosis, which is just simply too late. The final thing that we really looked at was, again, with this notion of courage, that courage what we heard was that courage is the same thing as social support, that they really cannot be separated. And that being supported and loved is the same thing as courage, that is the definition of courage. So you'll see that we really played on that in our communications messages. So the Valor Insights and Secret Sauce. So you can see on the right some of the examples of Facebook ads and Facebook posts. These were accompanied, of course, by a little bit of text and then an invitation to click on WhatsApp, or earlier when we were working out that tech of the direct click through, we also had numbers where somebody could just send a message. So, you know, if our insights are men are not only fearful, but they're very lonely in that fear, and they don't just feel ashamed, they feel ashamed of feeling afraid. So, you know, often we say, well, there's nothing to fear, but that is not validating their concerns. It's making them feel even more ashamed if they are feeling fearful. So Valor's approach celebrates courage and celebrates the courage that men have shown in other parts of their life. Social isolation, worse than death. You know, often we tell men to man up or face their fear. And instead, our approach promises that a Valor guide will be a trusted friend, helping them to connect with the courage that's already inside them. We reassure men that their families are still going to love them, that they'll be safe, and we give them like really solid reasons to believe that. And, you know, we meet men where they are with empathy and understanding. We're never implying that somebody was irresponsible. We don't care what brought you to this point. We're just happy that you're here and we're celebrating the man that you are right now. The last thing is that we are depicting really loving and egalitarian relationships between men and women, which was really interesting. Our men preferred those, asked for those. And so, you know, often we show images where men are in charge or men are being powerful in an interaction. And our guys in Nigeria did not want that. They really loved these pictures of these very egalitarian relationships. And you can see them here. So we basically have three key messages. Get tested because, you know, claim your courage. Your courage is on the other side of this fear. And you're not alone. You're going to find the courage because our virtual VIP guides will help you. You're going to keep what matters. You will have love. And why? Because breakthrough new treatment makes it so you can't pass the virus on to anyone else. And finally, you're going to feel good and you're going to thrive. You can still have fun and thrive because these new breakthroughs treatments are really easy. It's just one pill a day. So this is one of our Valor focus group participants said, you know, people are always making guys feel ashamed, but don't you know anything? If you massage a man's ego very well, you can get him to do anything. So also, you know, finally, I think we all know this. We just know this in our hearts that this is the right thing to do. No judgment, no shame, and importantly, celebrating men at every step. So I'm going to hand over to Ehi now to take us through the rest of the presentation. And if people have questions, I can be addressing those in the chat while she's presenting. Go ahead, Ehi.
Thank you. So like Mania had mentioned, Valor is a promise and it gives men a reason to believe. Our Valor message reached out to a large number of people with correct, consistent, and accurate information. The Valor actions insights we've gotten from other areas, which hinge mainly on three themes: claiming courage, keeping what matters, and enjoying life. One of the major benefits of Valor is the precise messaging on U equals to you, which provides an understanding that if you know your status, you keep your appointments, you take your drugs accurately, you can eventually become virally suppressed, which implies that you don't transmit the virus to those that you love. From our healthcare providers in the facilities, we found out that 2 in 3 of our clients who were informed about the U equals to you messages felt a lot more comfortable discussing around safeties for others and prevention to transmission methods with our healthcare providers. Following the initial small implementation phase, RISE has been able to scale up Valor so far by training over 100 healthcare counselor testers, case managers, and proprietors of clinical platforms on tailored valor messaging and counseling skills. We've also been able to develop key demand creation materials, such as valor posters and flyers, which are placed in areas where men frequent and in our facilities. We've also continued to provide HIV testing services to VIP guides that reach out through Facebook and WhatsApp. And we've been able to expand Valor beyond WhatsApp and Facebook to community platforms, and also modified our LAMIS, which is our electronic medical reporting system, to include Valor questions, which help us track the reach of Valor amongst our clients. And then for clients who have never heard of Valor, we use the counseling sessions to inform them about the Valor approach in a bid to enhance the support for these clients in retention, adherence, and ultimately viral suppression. Also, Valor has helped us to optimize self-testing and PrEP uptake in RISE implementing states. So this slide depicts engagement of our Valor VIP on WhatsApp and on Facebook with our virtual guides. Here, we also see the expansion of Valor outside social media to the community platforms in our mail lounges in RISE implementing states and on radio shows where message around Valor is also presented. At the 3 months of the small scale implementation of Valor, Valor reached out to thousands of men with anti-stigma messages and engaged the 920 men on WhatsApp who had inquired about HIV services. Of this number, 736 of these men were tested and 48 men were identified to be reactive and linked to care, giving us a 7% yield achievement. At the inception of RISE, we had a high testing target, which is reflected in this slide on the first picture there. But with COVID and targets being reviewed and numbers of testing dropping, with the inception of Valor, we continue to see that men were identified in RISE project. Before Valor, the proportion of HIV men identified ranged between 30 to 39%. And after Valor, that increased to a range of 35 to 44% in our program. For viral load suppression trends among men ages 15 and above, Valor has continued to increase in the RISE project, which is also a major contribution from Valor in spite COVID. Prior to Valor, the adherence rate and the viral suppression proportion among men in this age group ranged between 86% to 90%. And since the inception of Valor, this proportion has increased from 90% to between 90% to 69% in the RISE project. So the RISE team is clearly aware that there are quite a number of interventions targeting men. So the team decided to conduct an assessment amongst our clients to have a picture or an idea of number of clients that had seen one form of HIV prevention message on social media, and those that might have seen Valor messages in particularly, and how that influenced them. This assessment was conducted in the first quarter of FY22, and 44% of the newly enrolled clients who responded to this assessment mentioned they had seen a Valor ad, and that influenced their choice to get tested. Due to the Valor approach on RISE, RISE has been able to engage 10,194 men who have inquired about HTS services, tested 7,111 of these men, and we were able to identify 270 reactive clients who were linked into treatment, giving us a yield of 4% through the Valor approach on RISE. Next slide. So key takeaway for the team in general and key successes we're able to record. We identified that WhatsApp, shows a lot of promise as a medium through which Valor can be implemented across our states, and we can reach out to men. It also showed that it was also a platform that increased the acceptance of self-testing amongst men using the various valor platforms on social media in the community as well. And then also the mixed method, which was conducted after the scale up of valor, provided an opportunity for men to reach services and get support closest to them in RISE implementing states. And also the testing coverage on RISE, the contribution of newly identified positives and uptake of PrEP increased through the valor integration to the RISE project. Some key challenges that we identified with valor on social media was that we're only able to reach men who had Android phones and who were on social media, and that we're only able to link up with contacts, VIP clients who were residing in our implementing states. One other major challenge we identified was that in a situation where Facebook was on pause, it reduced or slowed down our valor activities during that period as well. In conclusion, valor has showed us that men are worthy and crave love, respect, empathy, and care. And valor has showed us in RISE a better way to reach out to men, to counsel with men in a way that is more acceptable to them and would make them accept HIV services and support. Also working with men to redefine and reframe their messaging has also makes it more desirable for the men to get tested, to be linked to care, and to ultimately adhere to those services. Also, the virtual platforms such as Facebook and WhatsApp have been identified to spark interest and drive behavior without necessarily having an interpersonal relationship with staff or RISE staff. And this messaging, the valor message, has been tailored in such a way that it helps with counseling of our male clients and ultimately has shown promise to help keep our men adherent to treatment and ultimately virally suppressed. Thank you. Over.
Oops.
Yeah.
Just to close out, I really wanted to thank our partners who worked on this with us. Man Global Health really helped us with with some of the marketing positioning. Anova, who is on the call, who's a partner on RISE, led the part about the VIP guide WhatsApp engagement. They did all of the training, all of the protocols for that part of this, and of course, ICAP and JPIGO working together to do that service delivery in both testing and treatment. So it was a really great partnership. And again, so much of this work and so many of these insights were building on some of the incredible work that you all have done. So here we go. This is our drive-by. And so this was a drive-by look at valor. And I hope that all of us go out into the world remembering to treat the men in our lives with a lot of love and respect. They crave our love. They crave our respect and care. And here they are, feeling like the VIPs that they already are. Thank you all so much.
Thank you so much, Manya and A. Excellent work, excellent presentation. I really liked how you looked at the campaign in line with the different outcomes across the HIV cascade, looking at the testing, being on treatment, and also the viral load suppression. I think that's really excellent to see hard data or the campaign speaking to the clear outcomes of the HIV services. Thank you so much. Excellent work. So we have got the last presentation before we go to our dedicated Q&A session. I want to encourage you to still continue posting your questions. We've seen questions coming into the panelists. Continue to do so. Also, let's make our chat box as lively as we can. The last presentation is work done in the ESA region. on male engagement. So there is a framework that was launched recently, and Marietta from UNAIDS ESA is going to give us highlights of this framework and the work in the ESA region. Over to you, Marietta.
Hi, everyone. I hope you can see my presentation.
Yes.
Perfect. So it's my pleasure presenting this framework to you. I think the last few presentations, which were amazing, thank you for that, really brought up a lot of points that are going to come up in this presentation as well. So it's really nice to see the coherence. So thank you for giving us a space to present this. My name is Marietta. I'm based in Johannesburg, where I work for the UNAIDS regional office as a gender officer. So as Licia said earlier, this framework was presented in mid-April this year. I imagine some of you were actually present at the launch, and I hope you've all seen the document, read it, and spread it far. So today I'm going to speak about the framework, some context, and give you a bit of an overview of the content of the framework and what it is and what it isn't. So talking about background, I'm going to keep this short because I know we are running out of time, and I'm preaching to the choir when I explain to you how men don't access HIV services, right? So one of the quotes we've been using a lot that I just want to share again is HIV prevalence may have the face of a woman, but AIDS mortality has the face of a man. So this discrepancy between transmission and mortality really shows the gaps of male engagement. I'm going to leave it at that and not throw around data. Another thing that I imagine is you're all well aware of is the impact of COVID. Still, especially because the framework has been developed over the last while, not taking COVID into consideration yet, I want to point out that the pandemic has changed and increased vulnerabilities, both of men and women, and everyone else in between and beyond, of course. But it's important for us to keep this in mind when looking at this framework and trying to implement, because obviously it has changed men's vulnerabilities in a specific way as well. So next is, I'll give you a little bit of context of how the framework came into being. And maybe some of you on the call were actually involved with that. So recognizing the gravity of the HIV challenge among men and boys and the diversity and the need to ensure effective engagement, it was UNAIDS in collaboration with UN Women, Sonke Gender Justice, the WHO, UNFPA, and Promundo, who embarked on the strategic exercise to strengthen male engagement. And there were different steps involved in this exercise. So it started with the documentation and analysis of effective engagement examples, some of which we've seen today. Then there was a consultation of regional stakeholders, and it resulted in a framework and in the launch of a clearinghouse. You can see the link to the clearinghouse here. I'll post it in the chat as well, together with a link to the actual framework, because this clearinghouse, this website was launched with the framework together in April. So now speaking more about the framework. So the framework is an overarching document to support the planning, implementation, and monitoring of the improvement of the HIV response in regards to engaging men and boys and all the diversity. So it starts with an analysis of the many factors influencing the low uptake of men of services related to HIV. So some of these barriers obviously are the product of prevailing harmful gender norms, which came up today in the webinar already. So like equating illness with weakness and viewing clinical settings as female spaces, which we heard from Uganda. So there's many factors contributing to the status quo. However, and I'm glad this point came up in the chat already, and I hope we can discuss that more in the Q&A. It's not just poor health-seeking behavior because of norms, it's also that men lack very crucial universal entry points to health systems that women and girls, because of their reproductive exposure, to call it that, have. So men do not have it and are more vulnerable and are more affected by limited opening hours, by only facility-based service delivery, because they work they more often are employed, they work, and they often work outside their communities. So we also have to really look at how do the services work and how can we bring men in as easily as possible. But then health system constraints go also beyond the service delivery level. And what we've seen very clearly is that in most countries, men and boys are simply missing from public health strategies. So we need to also create a broader enabling environment, which includes laws, policies, and health strategies that takes this issue into consideration. So now a little closer look at the actual framework. So the framework starts with an overview of the epidemic in the ESSA region. So it looks at the analysis of treatment and care cascade. Then it looks, as said before, at gender inequality and norms. And then it takes a close look at different methods of prevention, testing, treatment, mobilization, and messaging in order to improve adherence of men and boys. So for example, there's case studies and different examples to learn from, like specific ways of counseling and male-friendly clinics. And I'm going to mention these case studies later as well. And it takes, which I do not want to just say as a byproduct, but it also takes a very detailed look at men and boys and their diversity and what this diversity means in terms of reaching them with services. Okay, so I'm going to share a graphic with you, which of course I encourage you to look at fully in the document. So this graphic is really the heart of the framework. What it does, it outlines major strategies, which you see on the left, to embed male engagement in universal health coverage and the HIV continuum of care. So there's 4 strategies from top to bottom, which fit into 2 areas. It's either about structural enablers or programmatic areas on the continuum of care. And then on the right, which you should see now, yes, you are seeing accompanying key components for each of the strategies. So these include interventions across HIV, prevention, testing, treatment, care, and support. Yeah, so first, again, the first row, the blue one, is the strategy point. The strategy is the focus on structural enablers. So these support universal health coverage and HIV specific goals. So specific HIV prevention, testing, treatment, and adherence interventions rely on these broader strategies. And this is important because they are essential to engaging men and boys in the health sector overall, in the general health sector. So here the components, as you can see, include transforming social, economic, legal, and policy structures, as well as addressing supply and demand factors and gender norms. The next 3 key components of the strategies are focusing on program strategies. Yeah, which you should be able to see now. So these are these specifically happen through a differentiated care approach within the health facilities and of course in the communities. So here, as I said earlier, the framework really emphasizes on men and boys not being a homogeneous group, that they have diverse experiences and identities and following from this very specific health needs. And as all of you know, some groups of men and boys have a very distinct set of HIV-related health needs due to their specific risks and vulnerabilities, mostly due to age, sexual orientation, and many other factors, for example, poverty and inequality. So for example, as you can see here, men in prisons and migrants and sex workers are at specifically higher risks. So for example, just an example from South Africa, where I'm speaking from, here people in prisons are 2.5 times more likely to be infected with HIV than the general population. But generally, the framework puts in this element into the main graphic to really show and remind whoever uses the framework of the need of an age and population differentiated approach, because without that and without really looking at the specific country-specific epidemiological data, there can't be an appropriate HIV response. So the next one, just a very quick glance, is a gathering of the different HIV and AIDS targets, like the Global AIDS Strategy 2021 to 26. The main point here is, though, each country needs to set their own roadmap, their own timeline, and their own context-specific targets. Here is my last slide. I just want to reiterate what the framework is and what it isn't. It is not a toolkit that can just be implemented as it is. Rather, it is a summary and a guidance document to show what works across East and Southern Africa, and that provides an overview of what is required at country level to meet the globally agreed goals. But anything in between is really country specific. There is a whole list of specific steps to follow, but I'll leave that here. Yes, the clearinghouse, I mentioned that before. It is a really nice source because it's being continuously updated and showcases existing data and research on male engagement. We are also always happy for any submissions. So please, there's a contact address on the website. So please share with us what you're doing, and we're happy to share widely. Last but not least, I want to say that currently we have the framework in English, but it is being translated into French and Portuguese. We are planning national launches in at least Botswana, Rwanda, Zimbabwe, Swatini, Malawi, and Uganda. And we're currently working on different products summarizing the framework and helping countries to monitor and track developments towards the goal of perfect male engagement. And we are generally continuing to work with the partners, and I'm super excited to share those products once they're there. Thank you so much for your attention. This is it.
Thanks, Marietta, for such an excellent summary. I'll just send over quickly to Sean for the Q&A. Over to Sean.
Great, Licious, thank you. Let me start with the ones that we have in the Q&A box that haven't yet been answered in that box. A question from Aliyah on poor attitudes by health workers, seeing that across a number of countries as a barrier to services, and what might we do with healthcare providers to address that? Do any of the panelists have comments on that? I think that was specifically during Josephine's presentation, but all of you are welcome to jump in.
Yeah, I can speak to that a little bit. Something that we've seen, and I think something that I've been really impressed by is the way that our Nigeria RISE team, really the staff and the project team really connected with this idea of valor and making a person feel really valorous throughout their experience. And there's something about the simplicity of that that really is easily understood by everyone. Like, people know what it feels like to feel encouraged, to feel celebrated, and to feel valorous. So just that, perhaps Ehi can speak to exactly how that training rolled out of getting everyone on board with this brand positioning and tone, but something about the brand, and it's not a lot, you saw the pictures, it's not a lot of visual branding, it's not a lot of like bells and whistles, but that language, people are being treated like VIPs, they're being saying, hey, VIP. There's something about that that's been really easy for our service providers to connect with, and that has led them to provide a more empathetic service. Ehi, can you speak to how that training rolled out?
Okay.
Because I don't even know. Actually.
Yes. So during the Valor training, and even before that, RISE had consistently talked about the importance of providing person-centered care. At that point in time, it was called client-centric care. And throughout our different trainings and our engagement, we always carried a model that addressed that issue, because that was one of the initial problems or information we got from conducting self-assessment tests under the RISE project. So we made it, and it's a continuous intervention that we carry out throughout RISE, where we have a model that addresses issues around client-centric care, how to treat clients, putting them particularly in the shoes of the client. We have a model that we've tailored from the Jabago Gender Transformation for Health Toolkit that, puts our staff, healthcare workers, in the shoes of their clients. And that has really helped a long way in improving the client and care provider relationship and respectful care and services. Thank you.
You're muted, we can't hear you. So we can see you talk, but we can't hear you.
Sorry, go ahead.
I would say in my setting, one of the reasons, and this is on top of what other presenters have said, one of the reasons that health workers give for the poor attitude is they are overworked. They have a lot of patients coming to their clinics. We hope that having these differentiated service delivery models where, for example, with CLADS, one client goes to the clinic to pick the art, the interface between the healthcare provider and the clients is reduced. So seeing the poor attitude is equally reduced, but there is this one who still goes. And I like the idea that Manya has presented. I think it's Manya who said, treat everyone as a VIP. So if you go ahead and train our healthcare providers to treat that other one person who comes to the health facility as a VIP, you might solve the challenge.
Thanks, Josephine. Michaela, anything to add?
No, Sean, thank you.
Okay. Okay.
Thanks.
Good. Let's continue then. While we've got Manya and Echi on the line, question around what it took in terms of capacity building, and do you see that as being sustainable?
Maybe I would like a little clarification on the question of capacity building for who. So we did, I would say there was kind of 3 buckets of capacity building there. One is around cranking out content and social media content that is consistent with the brand and the positioning. So there was, we worked together with a local Nigerian communications firm. And we did a lot of work with them on message discipline and how, that every message needs to have like the call to, a call to action, a reason to believe, key promise, call to action, and reason to believe. And I think that that's often what's missing in some of our messaging communications as a community, is that we make a promise and we have a call to action, but we don't necessarily like nail down that reason to believe. And so, this is you can believe in this promise because, it's just 1 pill a day and it doesn't have a lot of side effects and doesn't have a lot of interactions with other drugs, and you can still drink or, whatever. So that's one kind of like message discipline. Yeah, I do think that that's extremely sustainable in the sense that we're going to have to continue to work with content creators. Content will not create itself on its own, but it is absolutely, it's our Nigerian counterparts and Nigerian staff who are doing all of that. In terms of training up the WhatsApp VIP guides, at the pilot stage, we worked with people who were already part of the RISE program and who were case managers, who were already using WhatsApp to do case management interactions. We wanted folks who really knew what it means to be to have a positive diagnosis and to really be on treatment. So, and there was a very intensive training of those folks right away, but it was all done virtually. It was all done over WhatsApp. And so it was not high cost. But yeah, of course, as you have matriculation, if you have people like coming and going, you need to do that. But that is now completely done by our own teams. And then finally, there's this part about all of the supportive supervision that we're doing all the time with healthcare providers. And that is an ingrained part of the program. Our hope is that it makes the interaction so much better for everyone. And it makes success so much easier for everyone, that it's much more gratifying to act in this way than it is to not act in this way. So I don't think that we're finding that we need to like keep prodding people who have already transitioned to this sort of approach, but certainly that there is a process of continuing to bring people into this approach at those different levels.
Great, thanks, Manya. A quick one while we have you. What are you seeing in terms of first-time testers?
I was looking at, we had so much data, we were just deciding what to show. we have a lot of first-time testers. Newly tested, the data that I was looking at is we were looking at like the equity spread on that. And when we started, new testers who were men were less than 30%. And now it's up almost to 50%. We've had a couple months where it's like right up against 50%, but it tends to be now between 45, like 40 to 50%. Before it was 30. So, and because the overall targets went down, that means that it's men who are pushing up. It is men who are the clients that we're continuing to get. So it is influencing new testing. It's also bringing men back into treatment who had been diagnosed but not been on treatment. A lot of them are saying hi on WhatsApp and getting back into treatment. We do have a 100% linkage rate, very, very good programming, but that's really on our care and treatment side.
Great.
And we have guys who continue to come back and like talk with their guide and tell them how it's going and check in with them. The guides ultimately have not been their long-term case managers. They do transition to a case manager who's their case manager, but they always know that they can come back to their VIP guide if they need something.
Great, Manya, thanks for that. Folks, we're short on time, so I'm going to pass back to Wole. I just want to note two things that I haven't gotten to yet. One is a comment from Morna Cornell around men and health seeking, and whether we should rather be saying that the health system is not really set up to encourage health seeking by men versus men are poor health seekers. And then another one around a couple comments from Dumisani in the chat around the question of whether we're disadvantaging women by developing programs specific to men. So maybe those are some things we can take up on another occasion. Just wanted to put those on the radar. And again, thanks to the presenters. Wole, I'll pass back to you for the closing.
No, I think absolutely fantastic. Thanks, Sean. I feel we've done amazing. We've had another really fantastic webinar. It just feels like we keep having quality people, quality presentations, really great engagement. So I'd like to just start by thanking everyone for this really amazing work, and amazing webinar. I think the impressive work that has been done by all of you that have presented is really well noted. I think it's just a webinar where we're presenting to people, but I just want to harp on the fact that the work and the efforts that you all are putting in is being noted, and it will be at some point appreciated in one way or the other, more elaborately, if you can, at some point. I want to thank all of our amazing presenters. I mean, Michaela, Kushimerwa, Ehi, Manya, and Marietta. I think the lessons that you bring to the table, those experiences are really key for us, and it will help us, drive the work as we continue to, push this really important work forward. Huge thanks, of course, to people we call them those behind the scenes. So the interpreters who have done really fantastic. Also the technical people who have made sure that we have a hitch-free webinar. I'm going to thank, of course, Lysias. Lysias continues to help us lead these webinars and organize them. He's been well supported, really well by the co-chairs of the Men and HIV Global Group, Mohammed, Afsa, Anna, and of course Sean, who's done really well to help us with the Q&A and keeping it quite succinct and brief. Usually at the end of the webinars, I try to have a few thoughts based on what has been presented. And the first, without going too deeply because of time, is how we think about men. Sometimes when we hear men, masculinity, and so on, you would be forgiven if you think we're talking about just one person. We're talking about one group of people. but it's just a note and a pitch to everyone to always remember the variety. You know, when we think men, we need to think diverse. We need to think heterogeneous. We need to think, you know, differentiated, and we need to continue to challenge the, you know, sometimes stereotypical way of thinking about men and how they behave and how they act. I think it's really important that you know, we challenge ourselves, you know, and move away from things that, you know, sometimes are only habitual, but wouldn't serve you know, how we move forward this work positively. You know, the second thing is something that was mentioned, you know, by one of the presenters, but it's come up as well in the Q&A. You know, are men poor health seekers, or do we have poor health services? I think that is the sort of way I would look at it. It's a conversation I think we can take on to further discussions and other webinars. But we have seen really good, you know, evidence, presentations, including in previous episodes of the MENT webinars, that men do seek health services. We had a fantastic one from Catherine in Malawi, who showed that, you know, of the men who come to the health services, who come to outpatient clinics, we haven't really taken the opportunity, you know, to engage them and to give them services that are male-friendly and services that they can, you know, access in a quality way. So that is a question I want to always, you know, I would like that to always tug on the sleeves of your mind. When we think about men, it may not necessarily be because they're health seekers. It could be that we're actually failing in how we respond to them and in the way that we provide services to them. The third, you know, came out really well in virtually all of the presentations. You know, it's about context, you know, how we put forward what we have into the different countries and the different contexts. So when we think men, we need to think context. We need to think local, you know. The best solutions, they say, are local. One size doesn't fit all. So that's another reflection that I want us to continue to think forward to, and how we implement and we approach our work on men. Finally, we've seen, you know, with the presentation on the framework with Marietta, you know, when we think men, you know, the work that has been done on the framework and how we have all collaborated together, you know, UNAIDS, WHO, Sunken Gender Justice, other partners in putting forward that framework has been really an inspiration. And we want to see that replicated in other regions as well. So partnerships, when we think men, we need to think partnerships, we need to think inclusive implementation, and we need to think you know, how we engage men, not just some men, but all men in all their diversity. Finally, you know, we continue with the webinar series. The next one is on the 14th of September. I mean, if the last few webinars are anything to go by, you can be sure that, you know, the next few webinars would follow the same line, and we will get really good presentations and engagement as well. So 14th of September, please have that on your calendar. And then the final one will be on the 7th of December. Have that as well on your calendars. Well, I think you should probably have those on your calendars as well. Please spread the word. You know, I feel a bit guilty. We had 100 people, you know, at some point in the webinar. But we need to share this. There's so much going on in these webinars and in this platform that we shouldn't keep it to ourselves. Let's put it out there. Let people come in and, you know, enjoy, you know, Manya, Josephine, Catherine, all the people that present for us. Let a larger group, you know, come forward and, you know, enjoy and take these lessons forward. On that note, I'm going to say, thank you. It's been a huge pleasure, you know, to close and to work with you, to see all of you. And I literally cannot wait for the next webinar on the 14th of September to continue this work. So take care and bye-bye, and see you all soon. Bye-bye.
Bye. Thank you so much.
Thank you so much to everyone. Bye-bye.
Bye. I need to first say that